Good afternoon, everyone. My name is Dolsy Sharma. I'm working as a clinical instructor in RTIIT College. Today, we'll discuss about the topic urinary retention. In examination, it is the patient warm, fever, abdominal, a tender enlarged bladder with dullness to percussion well above the symphysis pubis, often almost to the level of umbilicus. Look for phimosis, metal stenosis, and look for signs of infection in genitalia. In female, look for cystocele, rectocele, UV proplepsy, do a vaginal examination and look for pelvic masses, look for vulval infections and inflammations, gravid uterus, obvious thing. Do a DREPR examination in males, look for enlarged prostate, do a neurological examination to detect neurogenic bladder, blood test. Full blood count, urine and examination, creatinine, estimated glomerular filtration rate, blood glucose, prostate specific antigen. This is elevated in the setting of AUR, so is of limited use as that stage. Imagine studies. Ultrasound commonly used as it can provide a measure of post-void residual urine as well as looking for hydronephrosis and other structural abnormalities of the renal system. CT scan exclude intra-abdominal masses. MRI CT brain scan excludes space occupying lesions in brain. MRI scan of the spine used to look for disc prolapse, quada acuna syndrome, spinal tumors, spinal cord compressions. Cystoscopy, retrograde therapy or urodynamic studies. Management. Acute urine retention should be managed immediately. Decompression by suitable catheter. If possible, the use of chronic urethral indwelling catheters should be avoided. If the initial catheterization attempts are failed, call a doctor familiar with advanced catheterization techniques. Angulated cord catheter or a suprapubic catheter. For a people with BPH, the duration of the catheterization yet remain under investigation and studies. For example, while the author was interned, doctor catheterization for AU are done and the catheter kept is for 2 weeks with an alpha blocker like tamsulosin. If the prostate is palpable in a PR, DRE, fine stride can be started with tamsulosin. Neurogenic bladder related urine retention should be managed with clean intermittent self-catheterization. Few useful comments by American Association of Family Physicians. In a patient with AUR due to BPH, start a alpha blocker at the time of catheterization. Men with urinary retention from being prostate hyperplasia should undergo at least one trial of voiding without catheter before surgical intervention is considered. Prevention of acute urinary retention in men with benign prostatic hyperplasia may be achieved by long-term treatment with alpha reductase inhibitors X fine stride. Silver alloy impregnated urethral catheters reduce the incidence of urinary tract infections in hospitalized patients requiring catheterization up to 14 days. Suprapubic catheters improve patient comfort and decrease bacteriuria recatheterization in patients during catheterization for up to 14 days. Low friction hydrophilic coated catheters increased patient satisfaction and decreased urinary tract infection and hematuria in patients with neurogenic bladder who practice clean intermittent self-catheterization. As the management have a major role with catheterization, knowledge about catheterization is vital. Do not harm. Direction or the other order for catheterization always should taken by a qualified doctor. Do not allow anyone to catheterize a patient if he and she has no knowledge about genital anatomy and urinary tracts. Self-catheterization patients are obviously needing a training. Difficult catheterization, take a senior opinion, a surgeon, senior medical officer who has practiced with advanced urinary catheter techniques. Types of urinary catheters. Malicote wingtip, D-Pepser mushroom tip, Foley triple lumen, drainage, balloon inflation irrigation, balloon inflation urine drainage, 2 lumen, single lumen. Robinson catheter, plain straight catheter with 2 eyes, whistle tip catheter, Pezer catheter, Foley's catheter, 3-way Foley catheter, metal stillet, council catheter, insertion with Philform and screw-on stillet. Be familiar about the gauze of the catheters. Orange, French side 6 millimeters 2, red 8, yellow 10, white 12, green 14, orange 16, red 18, yellow 20, purple 22, blue 24, black 26. Contraindications for catheterization: urethral trauma, patients with pelvic fractures, blood at meatus, DRE high riding prostate, scrotal hematoma. TWOC, trial without catheter, considered for people who is especially presented with BPH. It is done to confirm the patient's ability to pass urine himself without difficulty. In TWOC, patients can send home without catheter, or sometimes a catheterization is needed. A suprapubic catheter will be clamped before the procedure. Procedure takes 4 to 6 hours. Catheter will be removed. Some water will be provided to drink. You will be asked to urinate when you have a urge. Then a doctor will be perform a USS to perform a post-voidal urine volumes in bladder. The trial is successful if you pass urine by 4 to 6 hours and have less than 150 ml urine left behind in the bladder. You can then go home. Take 1 to 2 liters of fluids when you go home for a day. Urinate every 4 to 5 hours. Keep a patient informed who was indwelling catheters about care, possible complications like UTIs. Read more about the catheter care. Thank you.